Hello, I'm Dr. Michael Danko, and welcome to another episode of Premier Pain Talk. I'm your host. I'm a interventional pain physician from Cincinnati, Ohio. We have four community locations in the Cincinnati area where we provide interventional pain services, and we also have a freestanding ambulatory surgery center that we opened last year. This is an exciting episode for me. I have our director of nursing, Jen Kraft, who's joining us for this episode. This is intended to be a conversation that kind of peels back the onion a bit on what actually goes into getting a surgery center started. So when I was getting that project going a long time ago, uh, it was so hard to get information about what goes into it. It just feels like this black box where it's you just can't figure out the recipe and to build this. And so there's different ways to do that, and I think that's why a lot of people will choose to go a route that we did not go, which was to go a route where you were basically self-funded. Joining a big ASC company or a big consulting group that can kind of take the lead and kind of do it for you. But there's a route to go where you can start it up yourself and you can kind of bootstrap it from the beginning, and that's the route we chose. Today I'm going to talk a bit about how we got that going, and then Jen and I are going to have a conversation about a lot of the steps that led us to today. So with that, I'm going to kick it over to our director of nursing, Jen Kraft. Jen, tell us a little bit about yourself.
My name is Jen. I'm the director of nursing at Premier Surgical Institute. So a little bit about me. I've been a nurse for over 10 years. I worked in critical care at Bethesda North Hospital, and I was a director of nursing at a different surgery center that was also a standalone surgery center, and that's how I met Dr. Danko. And then he decided to bring me on board with him, and I've been with PSI for about 2 years now. Um, and I've learned a lot along the way, and I will kick that off to Danko.
Yeah, absolutely. So I think, I was kind of thinking maybe we could title this episode like "What Not to Do with the Surgery Center." Sometimes that's the obviously this is a how-to or intended to be a bit of a how-to, but along the way there's a lot of learning that goes into it, and if I can help and if Jen can help with helping you get over some of these hurdles a little easier, then I think we've accomplished our mission for today. And this may end up turning into two episodes. We're going to start going here, and we're going to see where we go. I don't intend for this to be an hour and a half long podcast. So if it looks like it's trending that way, we may break halfway through and make this two different episodes for you all. So with that, I'm going to talk a bit about the earliest phases of starting a surgery center, and that really starts before any construction starts. That starts from can we actually do this? Can do we ha Have you picked out a location? Do you know where you want your surgery center to be? Is there other competition? And are you in a state that requires a certificate of need? If you're in a certificate of need state, it's going to be a much different conversation and a lot more upfront expenses and things to acquire that CON. So as we were getting the surgery center going, the first step is location, and we had this dream that at some point we potentially put a surgery center in our Loveland building, and at that point I knew nothing about surgery center construction, but I was really lucky that the size of the building allowed for some forgiveness that we did have the necessary size requirements to do that. So pick a location that has good enough size to do what you need to do. I mean, a small surgery center, you're going to need at least probably 4,000 to 4,500 square feet, but obviously more is definitely better. And then you think about what other kind of options are around. Is this going to be a location where you're going to try to bring on outside physicians and you're going to be more of a multi-specialty center, or are you going to do more of a single specialty that's more based on your own practice? Because location and who's going to come to use your facility can be variable depending on what you're trying to use it for. Then the next phase, once you've got kind of location picked out, before you even really, if you don't already own that location, I would highly recommend before even investing any money in it, you do a pro forma and some feasibility studies, and you figure out how you could potentially fund this project and decide if it's going to have staying power once it's all done. That's really hard to do to try to predict how you're going to perform before you've even broke ground. So You can use your historical case volume that you've been doing at other facilities, other physicians, what their historical case volume is. You can try to paint a picture of what has been done in the past to try to predict what can be done in the future. And then as far as, the ways to fund it, there's a lot of ways to fund it. The way we chose that worked out really well was we remortgaged the building and got a construction loan as part of that. And so we were able to kind of leverage the real estate we already had to move forward and get our project going. So then, as far as the next phase, you got to pick a contractor and then an architect, and you got to develop plans. And this is the point where you really need to have some consultants involved in the process, someone who's had experience with designing surgery centers and knowing what goes in and what's needed and what's involved. And they can work with you and your contractors and your architect to make sure that best as possible that you have a layout that's going to be conducive for all your needs moving forward. It's great to work with contractors that have done surgery centers before. They've done other medical spaces. Same with the architects, and then the consultants. The two kind of main consultants you're going to have are going to be somebody who has specialty in the accreditation agencies so like HHC or JCO, or whichever route you're choosing to go, and then a life safety consultant. And then once you get your construction going, then you kind of getting the ball rolling, and that's really just the kind of the very first phase of construction. And any of you who've done any big construction projects before, you know that is takes on a life of its own, and I could probably spend 3 hours talking about that rather than 3 minutes. So I'm going to kind of skip over the construction phase, and I'm going to kick it over to Jen and talk about what was the first thing we did, or what's the first step you need to do once your center is fully built and you're ready to start thinking about opening.
So so basically when everything is built, everything is ready, you make the decision of which accreditation route you want to go to. Because there's multiple different ones and they all mean different things. Premier Surgical Center is AAAHC with Medicare deemed status, meaning that we are subject to only Medicare surveys every 3 years because AAAHC has deemed us to be in full compliance for those 3 years. But you can go very many different routes with that. But the first piece of that is getting your Ohio or your state licensure. And with that, you have to have a certificate of occupancy, you have to have the fire marshal inspection, um, and then you have to just decide, when is the right time to apply for this big certification that you want to go towards. And that's when a medical consultant really is helpful when they are a surveyor and they can kind of coach you into which directions you need to go and how you need to be able to proceed with that survey. So we did that. That took probably about, I would say, 3 months maybe. When I came on board, we were just now getting into that process where the licensure for Ohio had already been done. We were ready for the AAAHC. So that was a big part of my onboarding where I was working with a consultant, trying to find the policies and procedures that fit our center appropriately. And then we were ready to go from that standpoint. And after that survey has been passed, that took about 2 weeks to get the final letter back. There are so many different things that you have to be aware of when you go for that. And it's not only the medical side and the patient safety, infection control, and the medical side nature, but also the life safety. Is your building safe for any kind of patient care emergencies for life safety? So our generator, for an example, um, big hospitals have multiple generators, but those are things that you don't even think about. You have to think about if something were to happen to a patient, what are you going to do in 15 minutes? So, to the electrical system, to the emergency lighting, to the task lighting, to the fire alarm system. Those are all things that go into that surgery center that is very, very helpful. And I have learned a lot on that because I don't think anybody really knew exactly what to expect from that standpoint. So that's kind of how we got into that survey aspect, but that was a lot of work at getting us prepared for that going forward. And then once we had that, we got the PTAN number, which is for Medicare, and that took about 4 months. So we were kind of in the wind with that, you know, in that aspect, because limiting factor is the patients that we could see, and we had to do 10 cases in order to get to that point. So finding staff members, sharing staff members, things of that nature to try to get to that point before we actually took off.
And then, so when we get into so I think the 10 cases before you can, apply, I think
Why?
that is such a hot topic among people who are trying to get a center going. Like, when do those happen, and what kind of cases they can be, and things like that. So, kind of at what point in the process do you do your 10 cases? So that occurs after your state licensure and before Triple HC arrives?
Yes, you have to complete those 10 cases before you can even apply for your triple HC license. And all of those surgery or cases have to be within your approved procedures that you're requesting to do at your facility. And it is, like you were saying earlier, being the solely owned ambulatory surgery center, finding those cases, finding the right cases, because ultimately they don't have, regardless of their insurance, we can't bill for them, obviously. So that's a big factor as well, because a lot of you also have to think about the supplies needed, the equipment. So all of that goes into being able to prepare for these 10 cases before you even apply for accreditation.
And then
So,
as far as those cases go, I think pain management, we have kind of I'm going to call it like a minor cheat code. So, we are not
yeah,
a big orthopedic group. We're not a big spine group. Like, we have basic procedures that can be done. And so that's epidural injections. That's, other kinds of, procedures that are not very cost prohibitive to acquiring 10 cases. There's not a lot of DME expenses associated with the cases that we can do. So, just for those of you out there that are in the pain space, just keep in mind that this is not, 10 spinal cord stimulator implants, and you got to figure out
right.
how you're going to pay, your vendor 200 grand before you can even have an approved facility. So, as far as as far as those 10 cases, those occur before the consultant arrives, but they are going to expect you to do a case while they're present and they're doing their surveys. So, let's kind of talk through what that day looked like for us on our end. Like, and what in general, um, when you want to get your accreditation, that they're going to come to your facility. And so, Jen, did we get to tee up exactly the exact date we were going to show up, or did they make us choose some dates? So what was it kind of like working with them, getting set up and ready to go for those for that inspection?
So they gave us, I think it was 3 to 5 blackout dates of the dates that they could not come due to, hours of operation and things of that nature. So after much negotiation with the Triple HC team of what days, we were available, and then giving us that 2 week window, um, I kind of prepared for certain days that they were going to come. But they were pretty spot on. When I thought that they were going to come, they did come. And which is very interesting for those that may be thinking about applying for the Triple AHC accreditation in the future, opening up an ambulatory surgery center. It is not a free survey, obviously, but a quick tip and trick, I guess, advice is they will send you the invoice and need that invoice paid immediately. And then then the next date that you have available, they'll be there.
Yeah. So if
Yeah.
anybody from Triple HC is listening, that's our we'll just say that's our hunch on how they do things. So
Yeah.
keep in mind, once you actually pay for your survey, there's a good chance they're gonna get it done in a fairly timely fashion, assuming it probably works with their schedules. But kind of real quick on blackout dates, just so everybody's clear. You have the ability as the one getting surveyed to pick a handful of times when you don't want them to show up. And so when you keeping in mind here, we're still talking pre-insurance, pre having anybody any way to get paid for these procedures. So you're not going to just have a full schedule going and they're just going to happen to show up. You're kind of in this limbo period where you're trying to make sure you have self-pay injections and other kind of procedures available that you can prepare for these days without really having a real strong mechanism for getting compensated well for that. So on the day of the survey, they were there pretty much the whole day. And so what was survey day like for us, Jen? Can you kind of step through in kind of generalities what the order of events was?
So they show up at They usually show up and they're sitting in the parking lot for about an hour before your doors open. But they were really nice. There's usually two of them. So there's a life safety coach and then a surveyor and then there's a medical surveyor. They go through all your policies and procedures. They basically, it's an interview, and most of it is interview and discussion. They want to look at your credentialing files. You credentialing the providers, and they have a checklist that you have to follow. But they give you all of this stuff well enough in advance to prepare for this. Obviously, they want you to be set up for success. So they give you all the tools. You just have to use those tools to apply to your practice. So credentialing files, employee files, those are all of some of the things that you need to do to prepare for those kind of surveys. And they kind of give you a timeline of what to expect when they're there. They'll ask you about policies and procedures and what you're going to do if this happens, kind of thing, kind of scenarios. They want to see your generator, and they'll ask you to turn on your generator. That was fun. That was exciting. But every state is different. So the things that they expect from life safety can be different. You just have to be able to talk through it and explain what's best for your facility and how you do things in your facility. Because not everywhere is Chicago, where it's like -30 every single day. That kind of things like that nature. So it did take all day. Actually took 2 days. And then at the end of the day, we did the cases. We did one case. And our female surveyor, she was very nice. She loved Dr. Danko, our medical director. Um, so they watched the case. We have to have basically two nurses in the facility at all times. We have a circulator. They come in the OR. They watch the time out. They make sure that's done correctly. They are very big sticklers on sterility. Did this person break sterile field? That's what they look for. And they watch basically the entire process. I think on survey day, we had only one patient come in because we already had the 10 cases out of the way. So that was pretty easy where we didn't have multiple patients in the facility and one person was trying to get everything done. And then we had a debrief afterwards. Um, and that was involving with the medical director as well. And they went over governing body, and I believe they went over our peer review process. They have a lot to do with our procedures, our governing body process, our credentialing process, employee files. And our medical records. The Medicare is very strict on what is included in every single medical record that you do, regardless of if it's electronic or if it's paper. That is very important. But obviously, like I said, they give you a checklist to prepare for. So you just want to make sure that your processes align with exactly what they are requesting. Um, I'm not sure. It was so long ago since we did our survey. Do you remember anything specific about that day?
Yeah, so for keeping in mind if depending on what your role is at the facility is going to be how much you're involved. So if you are listening to this and you're a physician, they're mainly going to be watching you do your procedure. I was not heavily involved in the survey. They didn't ask me a ton of questions. There were some basic questions that they asked kind of around that time, but in general, it was mainly Jen as our director of nursing who was quarterbacking most of that. They don't really, at least when I was around, they didn't really ask any questions to the other staff that were present, like your X-ray tech or anything like that. They may have when I wasn't around. And when it comes to the procedure, they're like Jen mentioned, they're really looking at your process with it. You're not going to get a grade on how well your epidural, how well your contrast flow was for your epidural or anything like that. They're going to be making sure that it seemed like the procedure was done with the right process, with a formal timeout, with good sterile technique. All the things that we're supposed to be doing on a routine basis, anyways. And then so st- when it comes to we kind of mentioned it very briefly when you started talking, Jen, about the deemed status. So I want to kind of hammer home on that just so people understand what that means. So there are two ways you can go about this. We can go through your Medicare deemed status or not. And so, Jen, just to real quickly again explain the differences between the two, and then a little bit of difference in the time frames, and then also if you go for deemed status, when HHC comes and does their survey, are you guaranteed 3 years, or could they potentially have you be for less?
So, with that being said, that's a good point that you bring up because if you get so deemed status basically is Triple HC joins with Medicare. Most everything, all of the policies and procedures that guidelines that need to be followed by Triple HC have a conditions for coverage, which is from Medicare tag aligned with that. So if you go with Medicare deemed status, that's basically stating that they um, you are considered fully compliant for the 3 years. However, if they can do a what's called a special survey, where if you have a organizational change, your medical director changes, your leader, like a director of nursing, changes or facility administrator, or if you have a change in your ownership, that those all can be, or if you have a change in your structure or environment, those can all trigger a special survey. Um, or if there is a patient event a negative patient event that happens and Medicare because you have to report those things. If Medicare finds out about it or somebody makes a complaint to the state, then you are subject to another survey. However, that's very unlikely that that would happen just because Medicare is very busy. So that's why they use Triple HC as their liaison for those. So that's very few and far between. So deemed status is basically for every 3 years they'll come back again, and that's when you have to basically reapply, and then you have to submit your entire profile again, and then you'll go pretty much go through the same process.
And then if you don't go for deemed status, it's going to be more commonly annual audits.
It's annual audits, yes.
Yeah. So it takes a little longer for the deemed status process. It probably took, I can't remember, but I think it took us about an extra, what, month maybe.
Mhm.
But on the back end of it, the benefit of that is that we only have to go through the surveys, routinely every 3 years versus on an annual basis. And then, there are kind of couple different phases of you getting your PTAN. So that was a drawn out process as well. So you need both needs to go through both your local MAC and national. So it's kind of two steps. And so we had a bit of a unexpected hurdle where I think it was our local Mac person who does the processes applications was like on medical leave for like,
Hmm.
our applications sat on their desk for what, 3 months or 2 months, and
Yeah, 2 months.
only in a government run program would there be literally no one to that's covering any of that stuff when somebody goes
Right.
on medical leave. So keep in mind that there are a couple different. It is a slow process. So Triple HC I think took about a month for us to get our survey results. It might have been faster, but I think it was about a month, and then Medicare took several months because I had to go through both your local MAC and national before you get your PTAN number. And then so once you get your PTAN number, you have a discussion of whether you want to go for Medicaid approval or not. So, and Jen, if you can kind of mention a little bit about the Medicare application, how long that took, and maybe some factors to think about there.
So, doing the Medicare application, it one thing I will mention is that the guidelines for HHC, they come out with a new handbook, and it's supposed to be every 2 years, but it has recently changed to every year. So you have to pay attention to making sure your policies and procedures align with the new version. And then this for the Medicare application, that also changes as well. So it might be the same in 2023, but it'll be totally different in 2026. So you have to basically take that into consideration. Um, there will be multiple avenues that you have to cross and things that you have to have available for a application of that nature. You have to have your readiness letter from your state. You have to have a transfer agreement with a local hospital. You have to have your fire marshal inspection within a year. You have to have your fire alarms tested, certificate of occupancy. So you have to be able to check all those boxes before you can even submit that application, or it'll kick back. And every time it kicks back, it takes another week. That is causes some kind of delay. So once that is all submitted and completed, then it's probably about 2 weeks. Then you'll get a email, and you'll start providing the blackout dates of the and preparing for your survey.
And then once you get Medicare and you get it took us about for on the Medicaid side. So
Hmm.
Medicaid, I think we should probably, obviously that is going to be very different from state to state probably. But
Yeah.
in Ohio, we chose to go get our Medicaid number for the facility as well, because a lot of patients don't have they have Medicaid secondaries, or some people have primary Medicaid, and we do some, injections for conscious sedation and different procedures that we want to make sure that as much as possible, as many people in our medical or pain management practice could come to our facility as possible. We didn't really want to have a barrier where we were exempted from Medicaid for our facility. So Medicaid took us about 4 to 6 weeks, I would say. Is that about right, Jen?
It is, yeah, it's about right. So I believe that's also kind of like in an order, whereas you have to have your Medicare before you can apply for Medicaid. You have to have, if you're going to apply for Medicaid, you have to have both of those numbers before you can start applying for a BWC. And then so on and so forth with our commercial insurances. And each one of those takes probably about 6 weeks, sometimes a lot longer. And then you get into the contract negotiations. So having that Medicare and Medicaid numbers will help move along the process. Um, and then you start with the contracts. Do you want to talk a little bit about how those contracts work?
Yeah, absolutely. So, I think what's kind of what just went through my mind a second ago is how casually we've talked about these timelines. And so when you're doing it, when this is your facility you're trying to do, um, every day feels like every week, every month, they all feel
Yeah.
like lifetimes. Where so
Hurry
this
up and
is
wait.
Yeah, so this is a slow process, so everyone needs to be prepared. The when you get your Medicare number, and that is traditional Medicare cases you can do. This is not a Medicare Advantage plan that can be done then. So Medicare Advantage plans don't come in through into your to your commercial contracts are done. So keeping in mind that you're not gonna be doing much in the way of cases for several months if you kind of were mentally adding up the different weeks and months that we just threw at you there. But once you cannot start commercial contracting until you have your Medicare number, your PTAN number. And then if you are choosing to take Medicaid at your facility, you cannot start your commercial contracts until you have both your PTAN and your Medicaid numbers. So once you have your Medicare PTAN number and you have your Medicaid number, if you're choosing to accept Medicaid, then you can start your commercial contracting. There are different ways you can get commercial contracting going, but they won't really accept your application until you have those numbers. So you can go through the credentialing component where you're getting like kind of they're going through your background and getting you privileges, so to speak, just like you would for hospital privileges. And then once you're, keeping in mind, this is, it depends how you set up your facility, but our surgery center is a separate entity from our clinic. So in the eyes of the insurances, we're a brand new business. We're not Premier Pain Treatment Institute with our contracts we've had for 9 years now. So, um, once you can get your contracts kind of prepped. You can get your insurance carriers mostly prepped, but then ultimately you're going to need to submit individual applications for all of them once you finally have your actual numbers. And then how quickly they get back to you is incredibly variable. Most of the contractors nowadays are going to a model that's more of a percentage of Medicare. So when you're doing your contract negotiations, I think it used to be a lot more common in the past to have grouper rates, where you could pick and choose the different groups of procedures that were most meaningful for you, and you could try to push for better reimbursement in those groups and give on some of the groups that you don't do commonly. You don't expect to do at all at your facility. But as we went through the process, there almost none of the carriers were really going to that model anymore. They were mostly going to a percentage of Medicare. So then you had to decide, was that percentage acceptable to you, and how much could you push? And the challenging part here is if you when you so this it's again it's a time balancing act. So you will reply, they send you a contract to look at. You might respond to them in like a day, and then they're going to take 4 weeks to respond to you or longer, and then they're going to send you another proposal or potentially the exact same proposal, and then you're going to decide how if you push back, it's going to be another month or two or longer before they're going to get back to you. So it's a bit of a cat and mouse game. There are some tips as you're going through the contracting process is trying to provide them with some data about cost savings can sometimes be marginally helpful. But ultimately, it's going to really come down to how many other facilities are in network in your area, and how much they feel like they kind of need your services. And you can request meetings with who you're negotiating with. It's good to involve your provider reps if you know who those are. But ultimately, I would recommend if you're going for this, you want to be north of 100% of Medicare as much as possible for your contracts. I don't think without sharing too much inside baseball, we didn't take any that were less than that. We're shooting for higher than that. When we go back to the beginning of this talk, the one of the benefits of working with a big organization like maybe a surgery center group that owns a bunch of surgery centers is they're going to have a much more negotiating power than you are. So and they probably have established contracts. They're going to be able to get you better contracts than you're going to be able to do on your own. So it's a balancing act. How much equity do you want to have in your facility at the end of it versus how much do you want to give up to help get better contracts and maybe have this process go a little faster? But again, we're kind of focusing more on a self-funded approach. So those are kind of, I think, some things on contracting that I think are worth noting. But once you get an acceptable contract from a carrier, Jen, can we do a case immediately, or once that effective date on the contract goes in, how much more time would you recommend waiting before you book your first case with that carrier, and why?
I would recommend when we get in contract and we, get the contract effectiveness date, I would recommend scheduling it, scheduling the patient, but I would recommend scheduling it like 2 to 3 weeks out because it's still everything has to go through a prior authorization, and um, we're talking about everything is on a timeline. So our timeline is much different. We're like, okay, let's go, we're ready. That's not the case with insurance carriers and medical review board for medical necessity. When we submit for a surgery for a prior authorization with the insurance company, they can take anywhere from 2 weeks to 4 weeks. And there's no sense of urgency, so to speak. There's millions and millions of people trying to get procedures, so there is not the sense of urgency there. So that would be my only recommendation to make sure, yeah, let's go ahead and try to do this, but not do this for 2 weeks out. Maybe wait 4 weeks so we can work towards that goal of making sure that that patient goes to the finish line, um, and doesn't have to come off before for insurance pending or insurance denial reasons that need to be appealed. And that's one of the things with an ambulatory surgery center that can happen. And there might be some roadblocks, but you just have to, for a new surgery center, you just have to figure out how it can be better streamlined. And you learn what not to do, and learning from your mistakes is key, I believe, to getting those timelines correct. And there's always going to be those one-off situations where you submit for a prior authorization for a surgery, and then it gets denied because of X, Y, and Z. But you learn from your mistakes. You learn what they need right away and why they didn't. So that's a very good, important fact that I would learn from, is to make sure, for if you're doing that with a brand new surgery center, to make sure that you pay attention to those little nuances so it doesn't happen the next time. But I do think that prior authorizations can be a real bear sometimes with brand new insurance contracts, especially.
So I'm already seeing this could be a great, kind of way to break this conversation into maybe two or three episodes. So I
Yeah.
think there is going to be a really good conversation regarding workflow and staffing and all the things that it takes successfully complete a day, a week, a month, a quarter, et cetera, in a surgery center. So I think we'll table that portion of it for another episode. But the last topic I wanted to talk about with you today is for the purposes of, we'll just call it we'll call it state approval, or basically days you can start your 0 to 10 cases, until your insurance contracts with the commercial carriers really start coming in. Um, just talk a little bit about staffing during that period, because as we mentioned, that is several months. And so in a world where you're, especially in a self-funded world where you don't have as deep of pockets as a giant health system, um, you don't want to be taking on a lot of full-time staff and other things that other kind of staffing expenses, because that can ramp up really fast. So in kind
Mhm.
of maybe let's call it, I don't know, months 6 through 12, the first 6 to 12 months, as you're waiting to get um, a lot of your commercial contracts start coming in. What would we do from a staffing perspective, or what would you recommend to someone who's trying to kind of to still operate kind of lean and mean during the waiting game?
I would recommend between those areas of months 6 through 12. Start interviewing. You know what your schedule is going to look like. You know what your volumes are going to look like as your business is starting to grow. So keep that into consideration when hiring staff. Hiring the right staff has staffing has been a challenge with our unique staffing situation. So keep that in consideration. And also for directors of nursing starting an ambulatory surgery center, think about your time and how much time it takes to onboard that one person. And I've learned what not to do. You might meet someone and they will not like it, and you have just spent countless of hours and money training and onboarding them when it doesn't work out. So I would use that into consideration to staff lightly, but you want good team players that are going to be there for you and be there for your business and want to make sure that it's supported and be there on the on your first case day. That's all I would say about that. Use yourself. You use yourself as a resource. Also, you are in, director of nursing, RN degree. Make yourself one of those team members until you can get up and running and you find the right people.
Yeah, absolutely. And then a couple of like maybe cheat codes that we used and our same X-ray tech doing our procedures in the clinic is the same X-ray tech who's is over there now with us. So we depending on what our schedule is, it just depends on whether Darcy's doing procedures in the clinic with me or one of their physicians, or whether she's in the surgery center, and we try to balance that. The our One of our medical assistants has gotten trained in being a scrub tech, and she is so when she's not in helping keep my life moving in the clinic side of it, she's a scrub for my cases in the OR. One of our other medical assistants is more of a patient care assistant over in the helping the nurses in the pre-op and PACU area move through their day. During the initial bootstrap, very beginning days, one of our nurse practitioners he was one of our nurses during the survey and during those initial 10 procedures. So I think there's some ways where you can see how much time and availability some of your existing staff have if you have those resources on your clinic side. But as Jen mentioned, when you're looking to bring in outside people who are not already part of your team, you got to really, I think, be really transparent and honest with them about the hours they might work and what they and PRN and part-time staffing can be a challenge, especially when these same people are also probably going and considering traveling jobs and other jobs that pay significantly higher. So when you're interviewing and when you're kind of taking through my only advice, so I get to do the 30,000 foot like backseat quarterback view of what Jen's doing for that. But my only recommendation is to try to make sure that you set very realistic expectations with these people, because it's a lot of time and effort that goes into onboarding for them to not work out. Jen, on the any last parting thoughts on kind of we'll call it the first 12 months of a surgery center before and then I think again, I hope we can find time real soon to record another one where we talk more about how we function on a day-to-day basis, but in the ramp up phase in this glorious waiting game that we played, any parting words of knowledge that you're thinking about?
During the ramp up phase, um, having a good medical consultant in your corner will help, especially, Danko, you've got four other practices, and having another RN to kind of be a mentor or just to kind of talk through the entire situation with and to get advice from. I would definitely recommend that for any director of nursing that's listening.
Yeah, absolutely. So, we're all smarter when we use the resources and it's always better to surround yourself with as many smart people as possible. So I think that's a great tip. So, with that, I think we've gone about, I don't know, 45, 50 minutes here. So I think it's a great wrapping point. Hopefully, most of you that have been listening to us in the car have reached your destinations, and if you're doing your workouts and you're working out for an hour, keep pounding on that treadmill for another few minutes here, and But all jokes aside, I'm Dr. Michael Danko with Premier Pain Treatment Institute and Premier Surgical Institute. We're in Cincinnati, Ohio. We have four convenient locations: Loveland, Mount Orb, Middletown, and Hillsborough. Our ambulatory surgery center, Premier Surgical Institute, with our fabulous director of nursing, Jen, is located in the same building as our Loveland Clinic. We have a website, www.premierpaintreatment.com and www.psisurgery.com. And our phone number for the 513-454-PAIN, PAIN, or 7246. And with that, we're going to wrap today's episode, and I appreciate everybody for listening.